Dr. Rife, it's all yours.
All right. Well, good evening. I appreciate you all tuning in tonight. And just to introduce myself, I'm Adam Rive, a podiatrist. I work at Desert Orthopedic Center, and I've been in the desert for about 3 years now. I worked for another private podiatry group before joining Desert Orthopedic Center. And then for 2 years before that, I worked in private podiatry in Riverside and Victorville. For my surgical training, I did a 3-year foot and ankle residency in New Orleans at East Jefferson General Hospital. And then previous to that, I went to podiatry school, Samuel Merritt University, which is based out of Oakland. And we rotate throughout the Bay Area. Undergraduate degree in exercise science, minor in business at BYU. And I grew up in Spokane, Washington. Podiatry piqued my interest when I was coaching high school pole vault. I saw how much shoes made a difference to the different athletes. And I shadowed quite a few different specialties. And what I liked about podiatry is it is a specialty, but we do a fair number of body systems in a confined area. And then that's my dog, Petey. He's just keeping an eye on us. All right, we'll move on to the presentation. So to start out, we'll talk about ingrown toenails. Basically, it's a knife digging into the skin. And it's a positive feedback process, meaning the more the skin swells, the more the toenail digs into the skin. This can lead to infections. It can even lead to osteomyelitis. Occasionally, it will calm down with Epsom salt soaks. I generally recommend 1 cup of salt per gallon of water twice a day for 20 minutes. The corner can be trimmed to relieve the pain. However, I generally recommend trimming the toenail straight to prevent it happening in the first place. Antibiotics can calm it down if it's a new infection. However, if it's been going on for a while, usually antibiotics alone are not enough, and it requires some type of procedure to remove the pressure on the toenail, either temporary or permanent. Now, the standard way that's done pretty much throughout the world at this point is to do a nail avulsion, either partial or full. I do a 2-stab injection technique to make a ring block around the proximal toe, apply a tourniquet, cut the toenail straight back. If it's a temporary, I'll try to cut more of a wedge so that when it grows in, the reentry has less chance of causing recurrence. The nail root is cauterized with phenol, which tends to be the least painful cautery agent. Some doctors prefer sodium hydroxide or silver nitrate, but they are much more painful if used. If a temporary procedure is done, it typically heals up in 5 to 10 days. Permanent procedure takes 2 to 8 weeks to heal up. And it's very important that when healing, the patient use peroxide, Epsom salt soaks, or saline to prevent a buildup of scab in the area. The dead tissue has to go somewhere, and it won't resorb in that area. And so they need to clean it out daily, or it will cause recurrence or a mimicking of the ingrown just from the clogged fibrous scab to the area. Does anybody have any questions regarding ingrown toenails?
Feel free to unmute briefly and ask a quick question if you do, and then please remute.
Are ingrown toenails genetic in nature?
To some extent. The shapes of our toes, our skin growth patterns, yes, but it can also be exacerbated by tight shoes or being really active. I don't know too many hikers who haven't had one at one point.
All right. Thank you very much.
All right. Now we'll move on to fungal toenails. So why do humans get fungal toenails? Opportunity. I think of it like a moldy shower. If you have enough humidity in the bathroom, fungus is going to grow, or mold will grow in the shower. And it's a similar organism. If someone has enough moisture in their shoe or in their socks, and if the toenail is injured or aggravated enough, it allows an opening between the nail plate and the nail bed where the fungus can start to attach and then start to alter the toenail. Treatment. There are many treatment options, and it's a very frustrating condition because it takes at least 1 to 2 years for most patients to treat. All of the treatments slow down the fungus, but none of them are necessarily fungicidal. So it depends on how quickly a patient's toenails grow. So a young child may clear toenail fungus in 6 months, whereas a retired individual, it may take 2 years. Specific treatment modalities. Laser has been around for decades. It's FDA approved to improve the appearance of fungal toenails, but not to cure the infection. Topical medicine is the mainstay of my treatment for our patient population, predominantly being retired, because it has minimal side effects and it's fairly effective. You can see curative rates in literature as low as 20, 30% and as high as 60, 70%. The biggest 2 factors I find in making topical medicine work are how much of the fungus you remove physically from the toenail bed by trimming or debriding it, and then how diligent the patient is at applying it daily. I typically, when I see a patient, I will trim it. I will use a Dremel to take it as low as I can. And then I recommend they file it before application every day to allow better penetration into the nail and to prevent buildup of old topical medicine, which may interfere with the new medicine reaching the toenail. Now, I don't recommend diabetics or patients with peripheral arterial disease or peripheral neuropathy to file their own toenails because they are high risk for infection with their feet. Now, much more effective is oral medicine. Most commonly is oral terbinafine, which has excellent coverage for dermatophytes, the most common fungus that causes toenail fungus. When I do use this medicine, I pulse dose it, either once a day for 7 days per month, or I'll do it 1 week on, 1 week off. There are quite a few studies showing this is just as effective as a daily dose. The other most common medicine I use is fluconazole 150 once per week. Now, I see a lot of patients who have had it, who have taken oral terbinafine for 3 months straight. And unfortunately, it typically returns the fungus because it hasn't fully cleared the toenail. And so when treating patients with oral medicine, we check their liver enzymes, try to ensure they're not taking any medicines that go through 3YP enzymes, make sure they don't have any liver disease, take a biopsy, standard of care at this point, to check for actual fungus growth on the toenail. I will say that with a caveat, I rely more on clinical findings because there are many false negatives with fungal nail biopsies and cultures. And then there's folk medicine. I've heard a lot, predominantly from the Chicago Podiatry School, recommendations of Vicks Vapor Rub, which there are some studies showing it has limited antifungal properties, and it certainly softens the toenail. But I haven't, in my practice, seen much curative from Vicks Vapor Rub. I've seen some decent results from patients who have come in and told me they used vinegar soaks daily for a year. But you do have to be careful. Vinegar is somewhat antibacterial, but not with all bacteria. So with patients, again, with diabetes, neuropathy, or PVD, I have seen them get infections from using vinegar soaks, or even Epsom salt soaks, which aren't fully antibacterial. Tea tree oil, I've seen some limited success, and I haven't seen too much success with peroxide soaks. Just to review back to the topical medicine, I typically use cyclopirox. I think it's a good balance between effectiveness and cost. The most effective topical in our market is Jublia or efinaconazole. However, most of the insurances don't cover it, and it generally costs over $1,000 per month in our area, though some of the Canadians get it covered. Topical tolnaftanate lacquer works fairly well, fairly similar to cyclopirox. Toverberol is a new one, but I haven't seen too much success. And then the lacquer or the topical solution of clotrimazole is okay. It's probably has the least spectrum of effectiveness against dermatophytes of the ones mentioned. I typically don't see any creams work to penetrate the nail bed unless I have first removed the toenail, which can be fairly effective. If I totally remove the toenail, don't touch the root, leave it intact, and then have them apply topical Lamisil or butanafine cream for 2 weeks. However, I shy away from this unless they have an ingrown toenail, because removing the entire toenail puts patients at risks for the new toenail to impinge upon the distal toe when it grows in. And so I typically try to treat it without removing the whole toenail first at this time. So any questions about toenail fungus?
All right, if you have a question, feel free to unmute and ask a question. All right, I'm not seeing anything or in the chat, so I think we're good to go, Doc.
One question, quick question.
Sure.
Is it, I mean, fungus doesn't look good, but is it a problem? I mean, if you just left it alone, live with it.
Yeah, I call it a barnacle for most patients when that question comes up. So most patients can live just fine with it. There are a few case reports of patients getting fungal osteomyelitis after having toenail fungus for many years. So in our population, I would just be cautious with our HIV positive patients. They'd be the most likely to have any issue, but it would be extremely rare. For the vast majority of patients, if they don't want to deal with applying the medicine, it's probably not going to hurt them at all.
All right, any other questions on that? If not, we'll move forward. All right, thanks, Doc.
All right, so let's talk about bunions. The medical term is hallux abductus valgus. That's because the hallux, also known as the great toe, goes into a valgus and abducted position. If you look at the top picture on the right, you can see the difference between an average foot and a foot with a severe bunion. One of the key measurements that foot surgeons look at is the angle or the space between the first and second metatarsal. It is an alignment issue with the great toe, but almost more so with the metatarsal that articulates with the great toe. And a successful bunion surgery must have that first metatarsal corrected to near parallel to the second metatarsal in order for it to not return. Many bunion correction procedures performed in the past have failed when the intermetatarsal angle is not adequately reduced. Now, there are a few bunions that are more predominant at the angle of the toe itself and can be corrected with a simple procedure of the phalanx or one of the toe bones, but most of them require correction of that intermetatarsal and work on the first metatarsal. So why do patients get bunions? Well, it's predominantly genetic. Now, certain conditions can make you more likely to get it, such as Ehlers-Danlos or other soft tissue disorders, or even rheumatoid arthritis. You can increase your likelihood of getting it if you wear tight, high heels for many years. Flat feet can increase the likelihood of having a bunion. And occasionally I'll see a patient with a turf toe injury where they acquire a bunion secondary after one of the ligaments or tendons has been weakened. Does any conservative treatment work? No, not really. But you can splint the toe, you can tape the toe, wear wider shoes, and a splint can hold it straight while you use it, but it'll always return back to the malposition once the splint is removed. Now, if it doesn't hurt, I almost always recommend, hey, don't fix it, because when I'm finished doing surgery on you, it's going to really hurt. But if there is significant pain with the bunion or ulcerations or other issues, it may be worth considering doing the surgery. Now, what is the best way to do the surgery? In my opinion, that depends on the patient. Surgery, in many respects, is an art, and so you'll get different answers from different surgeons. And if the patient's not sure, I will say, well, go talk to this surgeon, hear their opinion. And that's just fine. My go-to technique is minimal incision bunionectomy. That is the, let's see here, X-ray on the left of the 3 X-rays just below the bunion diagram. And so you'll see 2 screws on the first metatarsal and 1 screw in the proximal phalanx of the great toe. The reason I like this technique is I can get a very large correction of the intermetatarsal angle, and it heals much quicker than other techniques because we use a minimal incision. It's called a Shannon burr, but it's basically a drill with a cutting bit. And you can make a 0.5 to 1 centimeter incision to make your cut rather than a 4 to 6 centimeter linear incision. Additionally, you can use that same cutting burr to cut into the proximal phalanx to further correct the area. Now, when you do less dissection, there's less pain. And when you cut less of the periosteum, there's quicker healing to the bone. What's really made this technique successful, it's been around for decades, but only in the last 10 years has it become more standard, are the newer screw technique. We use cannulated screws that cross from the first metatarsal midshaft or base and into the first metatarsal head. And if you put 2 of those in, you can push that metatarsal head almost all the way next to the second metatarsal, effectively closing that first intermetatarsal angle as we previously discussed. Now, there's certain patients I wouldn't recommend this on, such as someone with Ehlers-Danlos, or maybe they have a severe flat foot. If that was the case, I would recommend the Lapidus or Lapiplasty, which is also an excellent technique. Both of these 2 techniques, I would say, are at the forefront of foot surgeons, whether podiatry or orthopedic surgeons today. The Lapiplasty or Lapidus involves locking or removing the cartilage to the first tarso-metatarsal joint, cutting an angle, so then you change the whole angle of the metatarsal and lock it at that location. Now, occasionally you still have to do some soft tissue or bony work at the metatarsal head. It does have an advantage of being less likely to recur and applying much more strength to the arch. Disadvantage is it takes longer to heal, and it's a much larger incision. It just depends on the patient whether I recommend one or the other. Now, let's say a patient has severe rheumatoid arthritis, severe degenerative arthritis, or hallux rigidus, meaning the great toe doesn't really move. Then I generally recommend a fusion or an arthrodesis. So that X-ray, the third one on the right, shows a standard locking plate that we use for that procedure. Now, the advantage to this one is it really can't return because it's locked. And you really don't have a lot of pain at the joint because, again, it's locked. The disadvantage is it's locked. So for some patients, it makes it a little difficult to get back to running. However, this is the preferred technique for athletes who want to return to jogging or hiking and have arthritis in that great toe joint. The final technique I want to mention is an oldie, but in my opinion, still a goodie. That is a silicone Swanson implant. That's the lower three pictures. Now, this technique is great for the right patient. You want someone who just wants to walk around to the bathroom, to the kitchen, to the car, someone who's not going to attempt athletics or even long walks around the neighborhood. If they're doing that, they will wear the implant out within 5 years. However, for someone who just wants less pain and wants a quick recovery time, we're not trying to heal any bone. So once the skin's healed and the swelling's calmed down, these patients are back to normal activity. Let's see here. There are other joint implants that have gained in popularity and waned in popularity over the last few decades. Most recently was a Cartiva, which was like a jelly bean that you would place across the first metatarsal phalangeal joint. Those have lost favor as they tend to resorb into the bone and cause issues down the road. And then there are metallic joint implants, which I don't like to do. They typically wear out, and then the patient needs to have a revision arthrodesis, typically speaking. But at the end of the day, if it hurts, I'm willing to entertain surgery with the patient if they're healthy enough to handle it. And then there are other techniques out there if they can't handle implants. But if it doesn't hurt, I generally recommend just getting bigger shoes. So are there any questions about bunions or bunion surgery or bunion treatment?
One question, I guess, is when you say getting bigger shoes or wider shoes, do you just go up a half size or do you go up a full size? What do you?
It's trial and error. So you have to go to a few different shoe stores. I give most of my patients athletic shoe recommendations to help get them on the right track. It's generally wider on the front. The other option is going to a cobbler and having them take a stretcher and a heat gun and adjusting your shoes. If you have leather or dress shoes, it might cost you $100 or a couple $100, but it's much easier than surgery. And so that's a great option. The shoe doctor in town does a really nice job on shoe modifications if you're just having a hard time finding anything that works.
All right, any other questions? All right.
All right, hammer toes. Why do patients get them? It's very common with neurological conditions where there's weakness because that leads to tendon imbalancing. Occasionally, the tendons on the top of the foot, also known as the dorsiflexors or extensors, will attempt to help lift the foot if there's weakness. And a byproduct of that is leading to toe contractures. The tendons on the bottom of the foot, same issue. They can become over-contracted in an attempt to push the foot. Additionally, there are supporting muscles called the intrinsics between the toes, which can become imbalanced with neuropathy or other conditions, and that can also lead to contractures. Treatment options. Conservative. There's nothing wrong with padding, strapping, or taping the toes, or wearing shoes that have a taller toe box so that the top of the toe doesn't rub on that area. I always recommend caution as someone who's numb and uses padding. If they don't check it, that can lead to irritation. And I've even had or seen patients who got infections from ill-fitting padding and bunion splints. Amazon is a great resource. They have more than anyone on different hammer toe padding, and I usually send patients there to try various pads. If it's the right toe, generally a flexor contracture, I offer a tenotomy procedure in clinic. It's very simple. I anesthetize the toe using generally an 18 gauge needle and release either both flexor or the long flexor tendon on the plantar aspect of the toe. Now, again, that has to be a patient with a flexor contracture. If it's a severe extensor or dorsal, I'll occasionally offer it, but usually not, because they don't reduce as well on the top of the toe when you release those tendons. But these patients are very happy when it's performed. I put a single stitch in, they return a week later, we remove the stitch, and they move on. And generally, I can target just the long flexor tendon, so they still have some strength to the toe. Now, to transition into surgical options, any surgical hammer toe correction has a high risk for weakness of the toe, or elevated toe, or a slightly malpositioned toe. There's a sequence when you do a surgical correction. You release the extensor tendon, and you also have to release what's called the hood. The extensor tendon basically fans out and connects to the entire dorsal aspect of the proximal phalanx. So you have to release that whole area. Occasionally, you perform an arthrodesis or a fusion of the proximal interphalangeal joint. Occasionally, I have to shorten the articulating metatarsal. Occasionally, I'll use an implant in the proximal interphalangeal joint. Occasionally, I'll remove the articulating metatarsal or transfer tendons to help pull it in a correct position. It is a bit of an art form, and I've heard it said many times in terms of foot surgery that hammer toes may be the most common thing we do, but they still may be the hardest thing to get right. Are there any questions about hammer toes or hammer toe surgeries?
Feel free to unmute if you have a question for the doctor.
What did you call the procedure that you do in your office for that? That you just use one stitch and people are pretty happy with it?
Yes, that's a flexor tenotomy. There's plenty of literature written on that. And you can use once in 5 years, I had to use a 15 blade because it was really contracted. But typically I use an 18 gauge needle because it's such a small incision that way. And, if someone has a severe contracture and they're getting ulcers, occasionally I'll do the extensor tendons, but generally not. For most patients who want a cosmetic and functional result, I stick with the flexor. Now, a particularly useful utilization of this procedure is when someone gets a callus or even an ulcer on the tip of the toe. Oftentimes doing this procedure leads to full healing of that area and removes a risk for osteomyelitis.
Okay, thank you.
Yep, you're welcome.
About shaving off the top of the bone so it doesn't rub on your shoes.
That's a great point. Generally, in that area, I shave a lot of bone on feet, but in that area, we have to cut it out because shaving it won't remove enough of it to get rid of the deformity. Now, there is an arthroplasty technique on that interphalangeal joint, which I'll do 30% of the time when I'm doing surgery on this. And that's where I just remove that bone that's sticking up, basically the little ball you see in that top picture on the right, on the second toe. We'll remove that, and that will allow healing to the area. So someone who doesn't need a particularly strong toe, for example, I had a patient return yesterday who had osteomyelitis and an infection and a wound off and on for a year. And first we attempted the flexor tenotomy and it got better, but she continued to have issues. And she was receiving IV antibiotics and wound care with this. And so eventually I removed the head of the proximal phalanx, that ball at the top of the hammer toe deformity. And she came back yesterday and she finally healed up. So that can be a great procedure that heals much quicker than trying to fuse that particular joint.
Hi there, can you hear me?
Yep.
I just question, it may be inappropriate for this lecture, but I've had tendon transfer on my toes and a hammer toe in the second that's had surgery twice, the second time an osteotomy. It's now pointing upwards. It rubs on the underside of my shoe. This is the second surgery on it. The last three toes, third, fourth, and fifth, had a tendon transfer to the side of the lateral aspect of the foot. They're now starting to curl under like hammer toes gradually. Is any of that fixable? Because I'm kind of tired of surgeries.
Maybe. I'd have to look at it. I'll give you a couple examples. When I first started at Eisenhower 8 months ago, the first week I had a gentleman who had some tendon transfers. His toe was pointing down, and so we were able to do an exaggerated flexor tenotomy just to release everything that was there. And it straightened up and it resolved. Another example is a patient who had 3 procedures done on her second toe. And it was a floating or a flail toe, which it sounds like what you're describing, where it points up. And for that one, we ended up removing the metatarsal head and putting a K-wire in it to hold it straight for a month. And I took some extra time to tighten the plantar ligaments at the metatarsal phalangeal joint. That's the joint where the toe articulates or connects to the foot. And it worked for her. Now, it wasn't perfect, but it was livable. It wasn't causing issues anymore. And then the other options are you can use a newer, they're called plantar plate repairs. It's a similar apparatus as was used in rotator cuffs, where you can hook the lower aspect of ligaments in the foot and try to pull the toes down and use a suture cable. But there are some different tools to bring that down, but it sounds like it would require surgery, and we'd have to look at it to know what would be appropriate and decide if it's worth the risk to you at this point.
Okay. Well, thank you.
Thank you.
Great question. Thanks so much. All right.
Neuromas in the foot, generally called Morton's neuroma. Once you see the anatomy, they're fairly straightforward. Why? It's a pinched and swollen nerve. So if you look at that picture right there, you can see basically a ball in between the knuckles, and it's getting pinched by a ligament. That's called the deep transverse metatarsal ligament, which holds the knuckles together. Now, the nerve, it forms a Y right at that point, and either pressure from the bone or the ligament causes it to swell, kind of like an ingrown toenail where it just continually swells until it becomes painful. And this can also be a positive feedback, meaning the more it happens, because the more it swells, the more pressure it causes to the area. Symptoms are numbness, burning, tingling, sharp pain. So what can we do to treat it? As with most things we've talked about, padding can be particularly effective, sometimes more effective than orthotics. If you go on Amazon and get a neuroma pad, they're shaped like a triangle, and they just go under the foot. Excuse me. And they cause the bones to slightly spread, which can decrease pain to the area. Again, that's a neuroma or a metatarsal pad. Or if I can show you them in the office as well. But even the orthotics generally have that built into it, which is the most effective part of the treatment conservatively. Shoes, either a rocker bottom shoe such as a Hoka or an Ultra or a Gravity Defier, and a shoe that's wide, because if the shoe's too tight, it'll cause the metatarsals to push on the neuroma. Other treatment options are injections. Corticosteroid are the most common thing injected, but you can also inject sclerosing alcohol, which can slowly deaden the nerve. Now that's great because the pain goes away, but it's can be bad because the sensation goes away too. And then surgical options, there's excision. You can cut out the nerve, totally remove it. If you look at the literature, it's a 40 to 50% success rate. The issue is anytime a surgeon cuts a nerve and leaves it cut, there's a high risk that it will grow a neuroma. So you get into the chicken and egg issue. I prefer to do a decompression rather than excision. So if you look at the lower right picture, they're just cutting the ligament. Newer research shows this is similarly and perhaps more effective than removing the nerve. And you have a chance to retain sensation to the area and less likelihood of recurrence if it works. There are many other treatments such as laser and ablation, but they're generally not practical. What I'm showing you here are the mainstays of treatment for this issue. Are there any questions about neuromas?
Feel free to unmute. There we go.
How often can you get an injection?
Well, if it looks like a neuroma, I'll offer it on the first visit. Generally for the injection, I prefer to just advance the needle in the skin. I don't like to puncture the neuroma itself. I just like to inject the skin and allow the cortisone to fall around the area. Now, a cortisone injection, you can do about 3 of those in that area per year. But one thing in this area we have to be careful is if someone has osteoporosis or osteopenia, cortisone, anytime it's injected, there's a risk for fracture. And you don't want to cause harm. So we have to weigh that out with the patient.
Thank you.
All right. Plantar fasciitis. I think there's a lot of groans going on out there because most people get this at one time in their life. The plantar fascia it's like the suspension of the foot. It runs from the heel bone all the way up to the toe or the toe articulations with the foot or the metatarsal phalangeal joints. And it's generally the first thing that gets overworked when our foot gets overworked. And because the whole band, it localizes at the heel, it generally hurts right where it connects to the heel. And it feels like heel pain to the patient. And now occasionally it can be in the mid-substance in the middle of the foot, but most commonly you see it in the heel. And it forms a cycle of inflammation. You walk on your foot or you do some big activity, you're feeling great, you get home, the fascia's been overworked, it's been slightly torn, or it has micro tears. And while you're asleep, it swells and it contracts. And you wake up, first step in the morning, it kills. And patients are always very animated when they discuss their symptoms because it's so tender. And it feels like more severe than what it is at times. So how do we treat this? There's 3 general areas you have to address. You have to stretch it, you have to support it, and you have to calm it down. So modalities for stretching, I generally recommend a wall stretch where your arms are on the wall, as on the picture on the left. You straighten your knee, you push your heel to the ground, put most of your weight on the forward foot, and then focus on stretching your calf. Do this for at least 30 seconds and don't bounce. Or if you're bouncing while you're stretching, it'll reactivate the muscle in your calf and you won't really get a good stretch. You're not going to loosen the fascia so much, or even the Achilles, but they're all in the same basic chain. And you will slightly lengthen the resting position of the muscles in the calf. This is the gastrocnemius and the soleus. Now, if you have the time, you can also do this with the rear leg that you're stretching. You can bend that to better address the soleus. Most patients, it's the gastrocnemius that needs stretching, and you keep your leg straight to stretch that particular muscle. So if you really have this condition and it's not hurting you too much to stretch, I recommend doing it 3 to 5 times a day for 30 seconds. If you're able to do that and get in some type of better shoe or insert, that's probably your best chance of getting rid of it and keeping it gone. Now, there's many other things we do to help. Physical therapy is excellent, and I send many patients to our physical therapy for this condition. And then there's night splints, which can stretch it while you're asleep. Now, to support it, it's better shoes. I always recommend getting better shoes. Certain shoes I see people getting this more with. People sometimes have an emotional attachment to their shoes, so it can be difficult to switch. Even my own mother, she came to visit last summer, and I had to drag her over to Lucky Feet to buy her new shoes. And then she called me 2 weeks later and begrudgingly said, yeah, she was feeling a lot better. So, and I would consider an athletic running shoe that's appropriate for your foot. So if you have a high arch, generally a neutral cushion. If you have a flat arch, generally a motion control shoe. Or if you have an average arch, generally an average stability running shoe will work better for your shoe type. But you have to try it out. It's not a hard and fast rule. Different shoes work better for different people. And then orthotics help many people. And so we'll send referrals for orthotics or recommend over-the-counter orthotics if I feel it'll help the patient. And then calming it down. Sometimes you have to calm it down before you can even attempt to stretch it. So unfortunately, you do have to rest, which is very difficult for our pickleball patients or patients who are just having the time of their life doing their activities. But you have to slow down a bit. If it's really bad, I'll put people in a cast or cam boot, which can be effective. I offer most patients a steroid injection. Unless there's concern for a possible calcaneal stress fracture, then we'll wait for the MRI to show that to be negative. You can take an oral pill pack for a week of steroids, commonly a Medrol dose pack. NSAIDs such as ibuprofen can be very helpful with this. CBD cream, or even custom compounding creams. If patients can't take certain medicines, I'll either refer them for CBD cream or custom compounding anti-inflammatory medicine. Now, let's say none of that stuff's working. There are pre-surgical advanced treatments, which are more regenerative. Platelet-rich plasma, commonly called PRP, is where we draw blood, spin it in a centrifuge until we isolate the platelets. Now, if you think about any time you have a cut, the platelets clot and they start the healing process. So if we inject platelets into an injury, it can tell the body to start healing the area. Amniotic injections can work similarly. The difference is those are pre-made and they're donated from the amniotic membrane or umbilical cord. Stem cells are possible, but I generally don't see it offered for this. We don't generally do stem cells for this because the cost is generally over $4,000 for something like that. One thing I do on the second visit, if we're attempting another injection, is I'll I'll do a little fenestration, meaning I'll first numb the bottom of the foot with some lidocaine, and then after prepping the area, fenestrate the tendon 9 to 15 times, which breaks up some of the scar tissue and stimulates the body to start healing it. Surgery has a very good success rate for this condition. It's generally a partial release of the plantar fascia. You can also do surgery to lengthen the calf ligament that connects the gastrocnemius to the Achilles. And I'll do this on certain patients. I don't like to do it on athletes because it will make them feel weaker when they're jumping or running. For the release, I typically do it open because I feel I can get a better release to the area, but you can do it with a scope, which I've done plenty of times as well. I've seen patients generally get a little better result when I make a 1.5-inch incision versus a 1/2-inch incision. So are there any questions about plantar fasciitis?
Well, my personal question, one that comes up is orthotics. Tried them in the past. Sometimes they work, sometimes they don't. Is there a tutorial about how to figure out what that is, or do you just go to a specialist?
Well, orthotics can be great and they can be terrible. A lot of the research done on orthotics is from the 60s from Dr. Root and Weed, and it was performed on cadavers. So they didn't get great feedback on whether the orthotics were working. I'll use them, I'll offer them, but I never guarantee that they'll work. I'll tell you the hardest feat to have an orthotic work is a high arch, because an orthotic typically pushes your arch up. And if you already have a high arch, that means your foot is rigid and it doesn't want to be pushed up anymore. So it's definitely an art form. Occasionally I'll order them myself, but there's a couple prosthetic places that I use in the area that I get very good results with, and have a fairly good price if they're not covered by insurance. But I get a lot of patients who say, you know what, they didn't work, I don't want them. So we focus on shoes and other techniques to support it and calm it down.
Great. A question that just came in. Can this also cause pain in Achilles tendon?
Well, they're on the same chain or the same cord. The treatments are very similar for plantar fasciitis and Achilles tendonitis. The main difference is you never want to inject cortisone into the Achilles because it's at high risk for rupture if you do that. So most patients that get Achilles tendonitis have plantar fasciitis too. But luckily, like I said, the treatments are fairly similar. You just have to be a little more careful with the Achilles, and you have to generally put it in a boot or restrict it for quite some time so that you don't have any ruptures.
So I just unmuted. I do have one other question too. That was me on the Achilles tendon. And that is, if you're doing the things like the stretching and let's say that you change your shoes, because I'm wearing flip-flops, which are probably not the best, but how long does it typically take to kind of, resolve itself without injections or surgery?
Are we
Typically.
talking the Achilles or the plantar fascia?
Well, it's like all over. It's like both combined. Yeah.
I'd probably say 6 to 12 months if it's both. Okay.
And at what point should I think at some point it's probably wise to go in and at least see the doctor, right? Like it's already been like 3 months or so. I've just been thinking it would get better, but maybe not.
Yeah, I think you're getting to the point.
Okay, thank you.
And on that same throw, follow up on that question, is hydration a component in this? If you're cramping, say, and you have plantar fasciitis, but is more hydration or lack of a consideration?
Interesting. I'm going to have to read up on that. Certainly cramping, hydration, and you could overhydrate and not get enough electrolytes, which could cause cramping, or get too many electrolytes. But in terms of the plantar fasciitis and Achilles tendonitis, I suppose theoretically, but I haven't read of any correlation there. Now I'm going to read up on it. So,
Fantastic. Any other questions on this topic? All right. Thank you, Doctor.
all right. So next we'll talk about tendonitis. We already discussed Achilles a bit. I want to talk about the supporting tendons of the foot and ankle. So on the outside or lateral side are the peroneal tendons. And on the inside, the main tendon is the posterior tibial tendon. Why do people get tendonitis here? Well, if you have a flat foot, you're more likely to get posterior tibial tendonitis because that tendon is continuously trying to pull the arch up. Whereas if you have a high arch, you're highly likely to get tendonitis on the outside of the foot because that tendon is trying to pull the foot in and pull the foot back down. And then there's certain exercises, basketball, tennis, anything where you're cutting, hiking, where you're frequently on uneven surfaces, and the tendons are trying to hold the ankle back up in a straight position, or just general athletics or walking and running. Treatment options. Conservative treatment options rest from the offending activity, a cam boot, if severe enough, anti-inflammatories, braces, physical therapy. Occasionally, you can do an injection in one of these tendons. I shy away from it, especially in our population, to do cortisone there because, again, with rupture risk. And then the regenerative injections, such as PRP, amniotic, are all applicable to this area. Most of my patients get better with conservative treatment on these issues, but occasionally I'll get someone who has a rupture or it just nothing works, and then we do surgery on it. And the surgery typically involves repairing the tendon, possibly a tendon transfer to reinforce whichever tendon is getting overworked. And then if you think of your foot like a tripod, we'll go into this a little more with the flat foot and high arch, but adjusting that tripod so then the tendon is not working so hard. Are there any questions on, well, let me go over to flat foot. We'll continue, then we can ask questions there. So going along with this subject, flat foot or high arch, which is called cavus foot. And patients mostly get these because of genetics. Occasionally, there's a neurological condition which can lead to flattening the arch. That's more common with diabetics or neuropathies where there's numbness, or an elevation of the arch, things like Charcot-Marie-Tooth. But even patients with strokes can begin to have a much higher arch due to imbalance of the tendons of the foot. Now, conservative treatment for this general foot type would be orthotics. If it's a flat arch, a motion control shoe like a Brooks Beast. Many patients have tried orthotics and then they use this shoe and that works for them. Or a Ritchie brace where the ankle still moves but it holds the arch up. That can be excellent. And then for the high arch, I typically recommend, again, a stability or a neutral cushion shoe, such as a Brooks Glycerin. So the shoe model matters. You don't want a Ford Mustang to pull a trailer. You want an F-250. It's the same thing with shoes. Same brands have different models for vastly different purposes. We were talking about that tripod. So if you look at the lower right corner, that's an image of a calcaneal slide. So you see the cut in the calcaneus and that plate. I generally don't use plates like that because they're bulky and you have to do a bigger incision on the side. Most people use a longitudinal screw, but that's not the point. The point is to show that when you shift that pivot point on the heel, it can make your arch go in or out. And so many times when we're repairing a tendon, we will add this procedure so that it's less likely to return. Okay, any questions on flat foot or high arch or peroneal or posterior tibial tendonitis?
Again, feel free to unmute if you have a question for the doctor or put it in the chat. All right.
Okay, finally, let's talk a little bit about general neuropathy, which commonly first manifests in the foot. Unfortunately, quite often neuropathy is a diagnosis where we can't figure anything else out, and you get labeled with neuropathy or peripheral neuropathy or fibromyalgia, a similar group of symptoms there. Not exactly, but similar. Now, why do patients get peripheral neuropathy? Well, most commonly it's diabetes, byproducts of continuously burning sugar stick to the nerves and cause them to first become extra sensitive and then eventually go numb. And that's not just sensation nerves. That can be the nerves controlling the blood vessels or other types of nerves. So it causes a whole host of issues. Alcohol can do exactly the same thing. Last year, I had a retired lady who was a socialite. She spent a lot of time at the club, and she complained of neuropathy, and we were talking, and she said, "Oh yeah, I drink 5 mixes a day." And we got her down to 2, and all her nerve symptoms went away. The other most common reason I see for this are back issues, or that's called radiculopathy or sciatica. And I work closely with many of our back or pain doctors where they do injections or stimulators or ablations. And quite often that works better than anything else to calm the burning, tingling, or numbness in the foot. Now, the other thing you have to remember, there's 1,000 other causes for peripheral neuropathy in the textbooks. And often it's just not possible to figure out why that particular patient is getting it. So the best way to treat it, again, address the cause. So treat the diabetes, lower the alcohol, see the back doctor. And HIV can cause neuropathy as well. And we see a fair amount of those out here. Now, and then we go in, I think of it kind of as the Band-Aid treatments, but that's unfortunately for most people are best options. So vitamins and supplements, B complex, there's more expensive Bs that are prescription only, such as Methanex. Alpha lipoic acid is over the counter and helps many patients with this. Pain medicines. Now, most doctors won't prescribe opiates, but gabapentin, Lyrica, even antidepressants such as duloxetine can help calm down the pain from neuropathy. If it's affecting sleep, many patients say that the best thing that works is lidocaine patches or cream. You don't want to use it more than 12 hours a day. There are quite a few studies showing that acupuncture is more effective than gabapentin for peripheral neuropathy. A newer indication is a spinal stimulator. However, it's not going to restore sensation, but it can help blunt the pain if nothing else is working. And then if you're having a hard enough time with it and you research it, there are some doctors, only a handful across the country, who will do nerve releases, similar to carpal tunnel surgery. They'll do this in the ankle and the lower leg, which can help, but it's not something that I offer routinely for neuropathy because it's the benefit and the research, it isn't there to support the risk. So a difficult condition, but there are things we can try for it. I think that's my last slide. So were there any other questions about neuropathy?
We do have one in here. It says, my first toes on both feet have lines on them. I've heard it can be a vitamin deficiency. What is your opinion? Because I also noticed that you have super vitamin B complex listed or on the visual.
Yeah. We would have to see it. Lines on the toenails, it can be from a range of things, from vitamins to melanoma, to a mole, to arsenic poisoning. There's quite a few things that can cause that. But vitamin deficiency typically isn't my first suspicion.
Oops, here, get a couple more questions. Before you go, back to nail fungus. Is it contagious and can it spread to other toenails?
Yes, it can be contagious. It can spread. Typically, I see it more as opportunistic. So if you have the right environment in your shoe, and maybe your shoes are too tight, or you're doing activities where your toenails are hitting the end of the shoe or really getting beat up, you're more likely to get it. There's some people who are around it and never get it. So yes, it can be contagious. It's not a bad idea to disinfect the shower floor if you're sharing. However, every day I see couples where one has it and one doesn't, and they're using the same shower every day for 30 years.
All right, back on neuropathy real quick, and we have a couple more questions. Is there a point that neuropathy is a problem that has to be addressed? Another age-related problem to live with?
More often the latter, something you live with. However, if you're numbing your foot, you have to use your eyes or get someone who likes you to look at your feet every day, because you won't know if you basically got a flat tire. And it can get out of hand really quickly if you get an infection, if you stepped on something. So that's the main thing. But it's better if you can get it under control, because it can lead to weakness. It can lead to difficulty walking, even difficulty driving. You can be recommended to lose your license, things like that. So if you can do something about it, definitely do it. But at the minimum, look at your feet every day. Just last night, I had to cut off quite a bit of tissue on someone who had a really bad infection.
Great. What treatments are available for gout? We didn't specifically address that.
Yeah. So gout is basically it's the body's, it's failing to filter out a certain powder. And that powder is uric, monosodium urate. The powder dissolves, but if you get too much of it in your body, it'll reconstitute as the powder, and it generally does that at the lowest point in one of your feet or one of your toes, excuse me, or typically on one side, but it can do both sides of the body, but on a toe or an ankle, but it can be in other joints as well. And the problem is the body attacks this powder or these crystals. And that's what causes the pain. That's what causes the red attack that looks like an infection. It hurts even to touch it. So if you chronically have elevated uric acid, you need to get on a medicine to keep that under control, so you're not having enough of that powder in your joints for the body to attack it. If you just have one attack your whole life, or once every, the textbook says less than 3 times per year, you can do medicines that counteract the attack. So cortisone, certain NSAIDs, medicine called colchicine, can all help it. You just have to be careful, because many patients who have gout also have kidney disease, and many of the short-term treatments can be really hard on the kidney. So you just have to be aware of that.
Great. I see someone unmuted. Feel free to ask the question.
Hi there. I'm the one with the toe problem amongst others. With regards to neuropathy, I have lower back arthritis, and I have the option of having nerve ablation in my lower back. But I also have neuropathy in my right lower foot, that he's not comfortable doing ablation for that. I have a lot of pain because I've had extensive reconstructive foot surgery. Is lower back neuropathy or nerve ablation, would that possibly help with neuropathy in the foot? It's
possibly
pain.
Yeah, it could possibly help. Your situation is unique, where sounds like you've had a lot of surgery, so you definitely have a possible cause for pain in the foot. However, if you've got back problems, 2 wrongs doesn't make a right. It takes more wrongs, basically, in this instance. So everything you can do to decompress or help with the aggravation of that nerve, because it could be the same nerve. The nerves from our feet, They go through our sacral lumbar area. And so if you feel safe about it, I would be optimistic that it could help the issues in the foot, doing the back ablation. But that's, you got to talk to your spine doctor. I'm not an expert in spines, but I do send a lot of people to the back doctor for that reason.
Yeah, he's not comfortable doing it, so I'm not
Oh, you mean, but he is doing the one in the back, right?
the lower back, for the lower
Yeah.
back.
Yeah, but that could help the foot.
But you have to get the right area.
Yes, definitely.
Okay.
Okay.
Great.
I
Thank you.
have a question.
Yes, go ahead.
Hello.
Go ahead.
I don't think you addressed this. I don't know if this is appropriate, but if you have I don't know, you call it a callus or a corn or something on the bottom of your foot where it's painful to step on it, is there treatment for that, or is that a common thing?
Oh, I do a lot of calluses. Yes, so typically I'll at least trim it down. We can see if there's a bony prominence causing it. Sometimes it's from a wart, so we can use certain medicines to treat the wart. But at the bare minimum, I'll take a blade and trim it down and try to at least get you some relief. Other options are padding or custom inserts, like not so much to hold your arch up, but to take the pressure off the area. But yeah, that's definitely something I see a lot of.
Right, and thank you. And also, do you recommend changing shoes every day, or if you find a pair that's good, is it okay to wear the same pair every day?
Well, you have to experiment, but in general, patients do a little better if they rotate their shoes. It's better. It's easier on the feet, and you'll get longer life out of your shoes. However, you don't want to rotate with a shoe that causes problems either. If I had to remove a couple shoes for my group, because I'd always get plantar fasciitis when I wore them.
Okay, thank you very much.
You're welcome.
All right. Well, we're pretty much at time. So, Doc, if you can go to your final slide, I don't know if it had if someone would like to know more about how to reach you or to schedule an appointment and those kind of things, how do they go about doing that?
Just call Desert Orthopedic Center.
All right. And then they did have a question in the chat, which led into that, which was, how far out are you on appointments if someone would like to make one?
It depends. If it's non-urgent, I'm probably a few weeks out. If there's an infection, I try to see them as quick as I can, but we take those as they come in. So.
Great. And you can find Desert Orthopedic directly online, or you can find it through eisenhowerhealth.org. And you'll be connected right there, and just tell them who you're trying to find, and they'll connect you and talk to you about your appointment schedule. All right. Well, Dr. Rive, thank you. It's very, very valuable conversation tonight, covering many things. And so thank you, everybody, for tuning in. And as I said before, this will be edited, and then we will be online probably within the next 2 weeks, if not sooner. And then I'll email it out to everybody who registered as well. So thank you for your time tonight, and we will be with Dr. Otorati on Thursday at 4:30 for our last lecture of the season to talk about rotator cuff injuries and more treatments for that. So join us if you have that issue. All right, Dr. Rive, thank you again.
Thank you.